Hey everybody, we are Group 4, and that includes Brandon Dyer, Caitlin Joyce, Todd Kaysen, Chase Penley, Dylan Roberts, Laura Beth Walker, and myself, Trey Wimmer. Like I said, we're Group 4. We'll be looking at Tracy Rush today, and in just a minute I will look at or give you a little more information about what her case looks like. Here are our objectives. Obviously, you've seen them before. They're much like, if not exactly like, your objectives in your presentation. So I'll let you guys take the time to read through those, and then I'll move on to the next part of the presentation. So here's our patient. Her name's Tracy, and she is a 28-year-old female Native American. She is a bartender, so she's on her feet a lot during the day, but is not at work right now because she was in a motor vehicle accident and was hit by a drunk driver. After that, she sustained or went through surgery and had a right transfemoral amputation. She was an avid runner before the surgery and before the injury, and which is something we're going to address a little later. Has a great support system, lives with 3 generations of her family, and it is worth noting that has sought legal counsel to press charges against the drunk driver that hit her. So you'll see in this diagram that there's a list of different people that'll be part of the team that can help Tracy get better. And just talk about a couple of them. We'll look at the primary care physician and the surgeon. The surgeon won't have a ton of influence in where we go after the surgery is done, but it will be important to refer back to his note. The physical therapist obviously going to be in charge of evaluating and treating the patient throughout the whole time that she's learning how to use her prosthesis, and even on from there, getting her stronger to where she can get back to work. The process is going to help make the prosthesis and fit it to her. Social worker is going to help her be able to get back to work, be able to help with any financial concerns she has and coordinate that kind of stuff. Maybe even get her back to some training or education she needs for her job placement. The DME provider is going to be able to give her anything that she needs or recommend anything that she needs outside of that prosthesis. The psychologist is going to help with any of those just mental issues that can go on with getting an amputation and dealing with body image, which we'll talk about in just a little bit. The pharmacist can be able to help her get the medicine that she needs and kind of go from there and get a game plan on that part. And the dietitian, as I mentioned before, she doesn't have a great diet, so the dietitian can help her get back onto a diet or an eating plan that can be better and benefit her healing and help her get back to normal as best she can.
Due to this being a traumatic experience, psychosocial issues are not uncommon. A strong support system will be necessary to facilitate the rehabilitation process, and it will be important to keep Tracy involved with as many of her usual life activities as possible. Some general concerns are that she will have to go through the 5 stages of grief, and as therapists, we should keep an eye out for indicators that the grieving process is manifesting symptoms indicative of poor coping. We call these complicated grief, and some of the signs and symptoms are severe isolation, violent behavior, suicidal ideation, workaholic behavior, severe prolonged depression, nightmares, avoiding to address the amputation, numbness or detachment, a preoccupation with a sorrow, and an inability to enjoy life. Real quick, I want to touch on a study by Halser et al. In 2014, and it found that patients who were post-amputation had significantly lower levels of body image perception and quality of life. The study found that many patients had significant differences in health evaluation, bodily pain, role limitation due to emotional problems, physical functioning, general health, and mental health concerns. Patient may feel embarrassed, shame, and other emotions following a lower limb amputation, and this may be a major limiting factor for them to return to their lifestyle activities. Many patients feel afraid that they will be less attractive and desirable. Other patients also feel afraid they will not be able to return to work and are afraid that if they do, people may judge them, something that Mrs. Rush may feel fearful of since she works in the service industry. In addition to feeling afraid of other people's opinions, patients who've undergone a lower limb amputation may also have low self-esteem and doubt their own abilities to return to activities they once loved. Here's a study on lower limb amputations conducted in 2012 to look at which coping strategies were most associated with positive and negative outcomes. In the first category, ineffective coping strategies, confrontative coping was not found to be very beneficial. This is where patients head on challenge all their problems and accept all the burdens they have, and focus on them. Another ineffective strategy was escape avoidance. This is actually the most commonly practiced, and it had the highest correlation with depressive symptoms. In fact, 42% of patients have major depressive disorder following a lower limb amputation. On the positive side, we have positive reappraisal. This is where patients try to reframe things that they view as problems in a positive light. Seeking social support was actually found to be the most helpful and had a high correlation to feelings of positivity. And this can be done either through counseling or support services, support groups. Planful problem solving was also very effective, and this is where patients kind of addressed, looked at all their problems, and strategized how they were going to overcome them.
So here we got two columns on the left. We're going to have some things that can maybe not so much help her, and it can be factors that can potentially hinder the rehab process. And on the right, we're going to have a list of things that can facilitate that rehab process. And so we'll start with on the left being the poor diet. Obviously, this is going to be a factor in how she heals, in the way her body looks, and how her BMI is affected. She did mention that her poor diet is due to the lack of financial resources, so those kind of go hand in hand. Patient divorced, which can be a negative thing and can affect you mentally, and having only a 10th grade education doesn't help her a lot when looking for a new job or having to deal with physicians and doctors talking to her and giving her big words and not explaining things correctly. So those are all things that can maybe not facilitate, but can potentially hinder the rehab process. On the right, we have the list of things that can facilitate the rehab process. Again, she lives with multiple generations of her family, which can be a great support. In the past, she was a runner, which shows me that she has good work ethic and discipline to go out every day and run, and also lets you know that she has a pretty good BMI and takes care of herself. And to go with that, she has no significant medical history. She's young, and she also has access to Indian Health Services, which is something we're going to talk about a little later. But that's going to be something that can really benefit her as well.
It has been mentioned that Tracy will be using the Indian Health Services as her provider for her healthcare. So, just some background on Indian Health Services. They are a comprehensive health services provider within the Department of Health and Human Services, meaning that this is a government run organization of care, just like the VA in a way. They provide services ranging from primary care, dentistry, rehab therapies, and so on. Even mental health is included. They are located on and around Indian reservations in many states, but they're not located in all states. They're mostly around the southwest and northwest of the U.S. and into Alaska. These services are provided to Native Americans and Native Alaskan individuals whom are part of the 600 federally recognized tribes. So they must be involved with one of those recognized tribes, and there is criteria within the tribe to make sure that you're validated to be able to be a part of that. There are many benefits and also many limitations associated with Tracy using the Indian healthcare services. I will first go over the benefits. It is a comprehensive care facility with an interdisciplinary team with the ability to communicate within each provider. She would have direct access to these services. It will also be with other people who share the same culture as her, so it has the potential to have a strong support system. Limitations would be that the IHS has a very low budget. They report they only have funds to cover around 60% of all the patient's healthcare needs. The IHS is not a form of insurance, and thus they will not pay for services at other facilities unless they are approved prior or it is a life-threatening emergency. Therefore, it is unknown to us how many visits of PT they will approve for Tracy before she has to start paying out of pocket at a private facility, because She does not have an additional form of private insurance. The examination will start just by checking the patient's vitals, just to make sure they're safe to continue. A pain scale will be taken at the beginning of the exam and throughout. Sensation will include the residual limb as well as the intact limb. Asking for phantom sensations or other concerns by the patient, as well as any sensitivity on the residual limb to give us an insight on how the patient will do with the future prosthesis. An integumentary check is important for not only the residual limb with the wound healing and incision and everything like that, but also the remaining limb. Because of the additional stress that has been put on that limb, we want to make sure that it's safe because of that. Range of motion and strength are needed values to get an understanding of the patient's ability in the future to don and doff a prosthesis, as well as just her ability to use it in the future. Balance and gait we'll need to know before she gets her prosthesis, and this will give the therapist a better idea of how she will handle a prosthesis in the future, as well as what kind of level she's at the moment. Of the 4 K levels that an individual can be identified as, we would identify Tracy at a functional level of 3. The patient is able to ambulate or has the potential to ambulate in the community, as well as some exercise potential. We don't see Tracy being able to necessarily run all of the time in the future for exercise, but it is a thing that she has liked to do in the past, and given her age and other variables, she would be recommended at a K level of 3.
Okay, so this is what an ICF model for Tracy might look like, starting with her body structure and function limitations. She's going to have some pain in that residual limb and be very reluctant to move it, especially immediately post-op. She will have sutures present when we first see her. She will have decreased right hip active range of motion, and just kind of general muscle weakness and soreness in other areas of her body due to this accident that she did have. And then edema will be present in that residual limb. Moving on to her activity limitations, she will have difficulty in being unable to transfer from chair to mat and back independently, unable to roll to her right side as well as prone. She may even have some difficulty rolling to that left side. She would require some assistance to get up to that sitting position as well from supine. She may be using grab bars to do that. And she could require contact guard and urging would be needed to help her ambulate at least one length in the parallel bars once we were able to move her down to a gym. And she requires minimal assistance to just stand on that left lower extremity, but does require some assistance for that. And then looking at her participation limitations, she will be unable to drive until she's fit with a prosthetic on that right limb, until she has changes made to her steering wheel to be able to steer with that upper extremity and use the gas and brake on her upper extremities and accommodate that loss of her lower extremity function. She will also have difficulty riding a motorcycle again without proper training for that. With the certain components of the motorcycle being on that right side, she may not be able to manipulate those with her prosthetic, and so it's just going to take a good bit of training and maybe some adjustments to ever get her back on a motorcycle. And then she will have difficulty returning to work, being limited in a wheelchair or a walker immediately post-op, and then obviously the time that it will take for her to become comfortable walking and ambulating for long periods of time on her prosthetic. So this just gives you an idea of some of the limitations and restrictions that Tracy may have.
In terms of the overall goal of the prosthesis, it needs to be comfortable, functional, and cosmetically pleasing in that order. If it is not comfortable, the patient will not wear it, and this will impede rehab. It is also important to consider that when energy demands for prosthetic mobility are greater than mobility without a prosthesis, the prosthesis is rarely worn. In terms of Tracy, her functional goals will include being able to return to work as a bartender. This requires her to stand for long periods of time, bend, crouch, and ambulate varying distances. Looking further down the road, returning to running in some capacity is a goal for Tracy, but that goal is not the primary focus for this prescription at this time. Tracy will need a liner made from polyethylene foam or silicone gel. This liner will act as an interface between the residual limb and the hard socket. It will also act to absorb some of the compressive and shear forces generated during ambulation. Upon discussion with the prosthetist, an ischial containment socket with a flexible rim was chosen for this patient. This type of socket is in worldwide promotion at this time and is replacing the more traditional quadrilateral socket. This socket is said to be good for medium to short, fleshy, and rotationally unstable residual limbs. However, it also has been described as being more beneficial for very active individuals. Judging by her age and past activity history, this socket will most likely fit the patient better. The high brim of the socket allows the ability to obtain and maintain suction suspension. The flexible rim will provide for better proprioception, better suspension, and greater comfort. In considering the knee component, understanding a basic concept in engineering can be somewhat beneficial. The 4-bar system is the most elementary, movable, closed-chain mechanism in mechanical engineering. It is composed of 4 bars that are hinged together, as seen in the picture on this slide, and it is very efficient in transferring power and motion. The human knee uses a 4-bar mechanism to transfer power from the muscles of the hip and pelvis to the leg. The 4 bars are created by the anterior and posterior cruciate ligaments, the tibial plateau, and the femoral condyles. The 4-bar knee joint prosthetic system allows for increased kinematics at the knee and will enable the patient to descend slopes and stairs more easily, crouch and kneel due to the approximately 130 degrees of knee flexion obtained by the component, and have an increase in toe clearance during the swing phase of gait. The silhouette foot was recommended for this patient. This foot is a flex foot or a dynamic response foot, and it is the lightest and springiest of the dynamic feet. This foot is recommended for individuals who are more active and walk at varying rates of speed, including jogging. This foot contains a compliant toe and dynamic posterior attached heel that allows for smooth rollover, natural gait, and a greater capability at attenuating vertical shock forces during heel strike. The compliant toe enables the patient to have a better push-off and terminal stance. This foot also does better over multiple varying surfaces.
The general prognosis for this patient is good. She had a very high prior level of functioning, and it's likely she'll be able to return to a lot of those activities to a comparable degree. She's really going to need a prosthetic as early as possible in order to help the rehabilitative process. And what Wick mentioned is that when it comes to her being the sole payer, sometimes it's difficult to get those prosthetics. So it's going to be important to make sure Indian Health Services is doing their part and hopefully paying for the prosthetic. We'll talk about them a little more. The incisions are clean, the borders are good, and there's no signs of infection. And so far her range of motion is all normal. And she's demonstrated compliance with all the intervention and has voiced an understanding of what she needs to do and what our goals are with therapy. So here are the positive prognostic factors. She has a very supportive family, and a large family at that. So whenever she needs help, it's likely that she'll be able to get it from her family. She is an understanding employer. Her employer so far has been very accommodating for her needs. Indian Health Services is an aspect we'll talk a little bit about more later, but they can help people of native descent pay for their medical bills. The lack of comorbidities is very good for this patient. She's only 28 years old and relatively healthy, so she should make a speedy recovery. And that also comes down to her desire to get back to what she was previously doing, which was very high level. She was a runner, and so she understands how her body handles stress, and she'll be able to hopefully understand and overcome all the obstacles of rehabilitation. So here are the negative prognostic factors, and the biggest one is psychological stressors, which you can imagine is going to be the case for anyone who's gone through this kind of trauma. She's going to need to redefine social issues, she's going to have financial burden, self-image changes. She's really going to need to be able to redefine who she is. and that can be pretty challenging. The second one is dietary concerns. Though this isn't specifically our domain, it is important that she's getting the nutrition she needs to be able to heal. So for these two things, we're going to refer her to a counselor for help and a dietitian. And the last one is financial burden. If Indian Health Services doesn't pay for a lot of the treatment she needs, a lot of the burden is going to come directly on her and her family. So what we can do to help that is get her back to work as quickly as possible. So we're going to emphasize a lot of vocational training and functional training, and it's expected she'll get back to work within 6 weeks' time.
Here we have written out short-term goals for our patient. The first goal addresses her body structure function impairment of having edema in her residual limb. The patient will independently wrap residual limb with correct technique in 3 days to ensure residual limb shaping and protection. The second goal addresses her decreased range of motion and reluctance to move. The patient will show no signs of contractures in the residual limb in 2 weeks to promote functional range of motion. The third goal addresses her current activity and participation restrictions of not being able to ambulate independently as well as be a part of her community at this time. The patient will be independent in wheelchair mobility in 1 week in order to promote independent community ambulatory status. The following long-term goals will address activity limitations such as standing and cooking and participation restrictions such as working and returning to exercise with friends. Our long-term goals are: patient will complete 1 day of work and all included responsibilities with breaks every 2 hours in 8 weeks to promote return to work full-time. Patient will jog 100 feet unassisted in 10 weeks to promote return to sport. Patient will stand independently for 1 hour while she cooks dinner at home in 8 weeks in order to improve functional endurance and address recommended dietary concerns. Patient will drive a car independently in an empty parking lot using the prosthetic limb to promote return to work in 8 weeks.
So Tracy would be identified by the Guide to Physical Therapy Practice at a pattern 4J, meaning impaired motor function, muscle performance, range of motion, gait, locomotion, and balance associated with an amputation. The guide anticipates that a prognosis for a course of care would be 6 months, including 15 to 45 visits. The guide anticipates that 80% of patients who are classified in this pattern 4J will achieve the anticipated goals and expected outcomes within this time. For Tracy, however, it can be expected to have around 25 visits for 2 times per week for around 12 to 13 weeks. We, like mentioned before, we're unsure if the IHS will provide for all of these, but this is the suggested time for Tracy that we think that she needs to attend physical therapy to accomplish all of her goals and perform at her highest level.
Weeks 1 through 5 should focus on functional rehabilitation in terms of pre-prosthetic training. Management of pain through the use of mental imagery has been proven to reduce phantom limb pain. Residual limb wrapping should also be utilized during this phase. The use of elastic compressive dressing helps to control pain, shape the limb, and limb maturation. Shrinkers can also be used after sutures have been removed and the draining has stopped. This will also help to shape the limb. Range of motion should be used for the residual limb and contralateral limb, especially at the hip and knee, to prevent contractures. There should be an emphasis on spending time in prone to prevent hip flexion contracture as well. Strengthening of the residual limb and contralateral limb should be initiated. The core and trunk should also be strengthened. Examples of strengthening exercises include bridging, straight leg raises, side-lying hip abduction, and adductor squeezes. Static balance should be initiated with progression toward dynamic balance during this phase. It is also necessary to use cardiovascular endurance because studies have shown that energy cost of walking in amputees is increased when the amputation is at a higher level. It will be necessary to meet the cardiovascular demands and the metabolic demand placed on the body. Home evaluation can be done as needed to modify the home. Railings, ramps, and modification of living space can be done. Promotion of community integration is important because studies have shown that body image and perceived social stigma can lead to depression in those who have undergone amputation. It is necessary to assimilate the patient back into a community setting in order to prevent depression. Mobility with an assistive device should be practiced in the parallel bars with single limb gait. Another component of mobility is the ability to use a wheelchair over long distances and to practice functional activities in ADLs. Driving adaptations and retraining driving should be initiated during this phase. Weeks 6 through 11 are focused on prosthetic training. Management of the prosthesis should be introduced, which includes education on donning and doffing the gel liner, as well as donning and doffing the prosthesis. Range of motion should be progressed from the pre-prosthetic phase to keep full range of motion in both the residual limb and contralateral limb. Strengthening of the lower extremity musculature and trunk musculature should be progressed from the pre-prosthetic phase to the prosthetic phase of rehabilitation. Cardiovascular fitness and endurance should be progressed with the use of the prosthesis. One study showed improved cardiovascular endurance utilizing a home-based treadmill training program. The program was 30 minutes a session for 3 times a week for a total of 8 weeks. Incorporating balance with the prosthesis can now be added. The use of PNF on the residual limb in conjunction with traditional dynamic balance exercises was found to be effective. The use of rhythmic initiation, approximation of the prosthesis, and resistance applied in an antagonistic direction of the residual limb were used to help improve balance with the prosthesis. Mobility, functional activities, and ADLs should be progressed from the pre-prosthetic phase now that the patient has the prosthesis. Driver's training can now be intensified because the patient has the prosthesis. The patient should be encouraged to participate in the community while wearing the prosthesis as stated earlier. Gait training with the prosthesis is the main component of this phase. Weight bearing through the prosthesis can be initiated and progressed to standing balance. Weight shifts are then incorporated while standing. Ambulation with an assistive device should be done at first in the parallel bars. As the patient progresses, ambulating on stairs, even surfaces, uneven surfaces, and ramps or inclines can be added as the patient becomes more efficient during gait. One study found that the use of perturbation-based gait training in a virtual environment was effective for patients with mediolateral instability. In this study, the patient walked on a progressively destabilizing virtual environment for 8 sessions. The perturbations were customized to roll and pitch with the virtual environments to challenge gait. Transfers, balance, and safety should be practiced with the use of the prosthesis. Transfers should be practiced on different surfaces, such as transferring in and out of the car, in and out of the bed, onto the couch, bathtub, and other things at home. The patient should also learn and practice how to fall safely and then how to get back up properly in the event of a fall. Lastly, the patient should be educated on checking the residual limb daily for signs of tissue overload as well as limb hygiene. Education on the maintenance of the prosthesis should be implemented.
After about 5 to 14 days, the patient will be discharged home. During this time, the patient will rely on the interdisciplinary team listed on this slide for pain management, gait and functional training, including ADLs, strengthening, balancing, wheelchair and crutch training, as well as using the prosthesis provided by the prosthetist. A social worker will be important for financial aspect, as well as the psychologist for helping her and her family adjust to the drastic change in body image and function.